Okay, great. Thank you. We will try to keep this as interactive as possible. And this is actually a real live patient. He exists. He's not fictitious. I thought I probably should tell you my conflicts of interest. I have none, but for different reasons. No interest in doing ad boards, no time to do speaking talks, and I am a homeowner in Vancouver, so I have no free money with my soul-crushing mortgage. So this is an actual patient in my practice, and I'm going to sort of skip to the end and tell you that he had a good neurological outcome, but I think there's many nuances of the case that would merit discussion here. He's a 79-year-old gentleman. He's had no prior cardiac history. I actually saw him once about 8 years ago when he was referred by his GP for the evaluation of shortness of breath. Other than a remote smoking history, he's got no cardiac risk factors, and had a fairly unremarkable past medical history. We diagnosed him with COPD after he came back with an abnormal chest X-ray and PFTs with a normal echo. We did not do an ischemic workup as we didn't think that his clinical symptoms warranted it, and we had a fairly good alternate explanation for his symptoms. Anyway, he was then lost to follow-up until he had a fairly dramatic presentation to our hospital. He actually collapsed in front of a high school, walking his dog as his usual case. And a 12-year-old girl, who actually was now profiled in the CBC, ran to his aid and immediately started doing CPR and yelled and screamed, and someone called EHS, who got there in 10 minutes. And we have two different kinds of ambulances in British Columbia. BLS and ALS. The ALS guys are the ones with the LifePak 15. So an ALS crew with a LifePak 15 came within 10 minutes, and the initial rhythm was VF. He was cardioverted once with immediate ROSC. However, he had a very low GCS. It was intubated on the scene. I'll let you read the rhythm, but I'll show you the actual ECGs. And the blood work was drawn. The hemodynamics that you see was the initial hemodynamics in the trauma bay of the emergency room. So I'll show you the progression of ECG. So this is his baseline ECG here, which shows a right bundle branch block with some sinus arrhythmia, but otherwise fairly unremarkable. This was back in 2012 when I saw him. This is his immediate post-ROSC ECG. There is a lot of baseline artifact, but after sort of close squinting, even the electrophysiologist believed that this was atrial flutter with his same right bundle branch block, but you'll notice that the QRS complexes are wider, and he's got more ST shift in the right side of precordial leads, as well as a suggestion of some ST depression horizontal in nature in the lateral leads, but these are fairly subtle. One of the fellows commented on the possibility of ST elevation in AVR, which, again, it was not present to as much of an extent in the baseline, but was something that caught their eye. 90 minutes after his post-ROSC, he then developed complete heart block and impressively widened out his QRS to now include a left bundle branch block. So before he came in with a right bundle, now a left bundle. This led to the emergent implantation of a transvenous pacemaker by the fellow in the emergency room here. His blood pressure here, I believe, was in the 90 to 100 range. So he was not completely in shock, but clearly electrocardiographically he had deteriorated, and hemodynamically had not gotten much better. So, with this in mind, who here would treat this man with targeted temperature management? And if so, I think the answer to that's probably yes. I'm interested in both the panel and I'm interested in the audience. Show of hands, who would use 33? Who would choose 36? Okay. Any comment on in the panel here as to why you would choose 33 and 36? We chose 36 as well, and this is coming from someone, me, who was a very fervent 33 biased person. I was dragged kicking and screaming from my biased view of TTM, and now I'm more of a 36 guy. So.
Yeah. My comment is that in my trauma population, I measure oxygen in the brain, and we know from studies, small studies in human, that if you go down below 35 degrees, the delivery of oxygen to the brain might be decreased. So I was very happy to have the TTM trial come out. And if I do decide to go lower, I never go lower than 35 nowadays.
Interesting.
And Nick?
I think we have much less complication at 36 and 33 in terms of temporary pacing leads and things like that. And anecdotally, probably less aspiration pneumonia, so.
As well, I think the resuscitation time with BCLS was fairly quick or almost immediate with the young girl, so it kind of does fall into the study population of the TTM trial, so I would stick to those numbers.
Yeah. And don't you think we see also less shivering, less problem? We have given medication and everything, and that complexify the whole thing. So I think it's make it simpler, and that's why I choose 36.
Agreed. Now, another question with respect to the initiation of TTM, who would have started it in EHS, in the ambulance, or would you have started it in the emergency room or somewhere or in sometime else? Who would here have started it in the field? Have the person sort of already cooled to some degree before they came to the hospital? Show of hands. Who here would have started it in the emergency room? Okay, so fairly uncontroversial, and I think because of that, I'm going to blast through these next little things here. So I think Anik has very elegantly outlined the meat of the landmark trials in 2002. I won't spend a lot of time going over them, but the main things that Anik had pointed out was that the two trials which showed benefit of 33 versus placebo was limited by a number of factors which in retrospect are pretty glaring. Number one, relatively small numbers of patients, a fairly, I guess, rudimentary approach to critical care, and which led to that marked difference in mortality between TTM and the placebo arms of Haka and Bernard, and a very high risk for bias. She also nicely illustrated the fact that at least in one of the trials, the control arm wasn't true normothermia at all. In fact, if anything, it was hyperthermia. So this led to a recommendation that TTM be used in all unresponsive survivors with an initial shockable rhythm. And the basis of that was basically the TTM trial. These are what we thought were the pros and cons of TTM. The study population, clearly a different population than back in 2002. It utilized much more modern ICU care, predefined protocols of withdrawal of care, and the temperature targets were much better defined. So on the basis of that, we believed that the trial of TTM sort of trumped the two landmark trials there. We did not believe that there was any evidence that would pick one temperature versus the other. We debated about this in a great amount of time. There was a competing paper that was published in the Canadian Journal of Emergency Medicine with a simultaneous publication resuscitation by a bunch of Canadian emergency room doctors who fairly firmly recommended 32 to 34. And that is distinctly at odds with our recommendation. And there were some methodological issues that were different in terms of our interpretation of the primary literature. But we believe that a range is appropriate, but if you pick a temperature in that range, we wanted you to keep in that range. So what we didn't want people to do was go to 33 but feel good about then drifting up to 36, or going to 36 and then allowing to drift back down to 33. With respects to the benefit of pre-hospital use of TTM, 7 trials that we looked at, only one of which was a good quality trial. This was actually presented at AHA the same time as TTM. Probably did not get as much press as TTM did, but very clearly showed not only no benefit, but a signal towards harm at using pre-hospital TTM. Now, it could be argued that the methodology about which TTM was given in the pre-hospital setting in this trial could have contributed to the harm because they used cold saline as opposed to alternate methods. After this trial, I don't think there's a lot of enthusiasm at doing another pre-hospital trial with alternate methods of cooling. I don't know if anybody here wants to comment on that. So we don't recommend the use of chilled intravenous fluids, and in the absence of any other studies, we can't extrapolate whether or not other methods are useful, so we just don't recommend it at all.
In the pre-hospital setting, because it's the quickest way to cool someone in. But I think this relates to the fact that the patients are not stabilized enough to receive therapeutic hypothermia, which is another important criteria in my mind. Cardiogenic shock, no way we go down. You can do TTM, but not lower. They have to be stable.
Okay. Next, yeah, there we go. Okay. We did have, I guess, a little clause in the values and preferences section because we realized that in the Canadian landscape there is a possibility of very long transport time. So if you're sending someone from the hinterland to one of the PCI centers, an hour, 2-hour transfer time, that would encompass the window in which we know that TTM works most effectively, and that there might be some leeway to negotiate initiation of TTM. So maybe I'll spin this to the panel here. You have someone who is up in James Bay, and they're being flown down to the Montreal Heart for advanced care after OHCA. And the question is, do you want us to cool them? And it's going to be a fixed wing or a rotary method of getting you down 3 or 4 hours.
They go to Miguel.
Okay.
James B. Go ahead. Want to handle that?
So
Yeah.
I'll start. Again, I think what Francis said, if you can initially evaluate the patient in the emergency room, make sure he's hemodynamically stable, there's no other cause for his cardiac arrest like intracranial bleed or other causes of non-cardiac cardiac arrest. And if you assume the ECG has criteria for either acute coronary event, I think it's reasonable to specifically stick to a 36 degree temperature as opposed to having it drift down too low where you might get all the complications of profound hypothermia or someone who might, through various mechanisms, uncontrollably go much, much lower in temperature if they're using ice packs or cold saline and so on. So I think if you are to have a fairly reasonable diagnosis of a ischemic cardiac arrest who's stable, who's not in shock, I think it's reasonable to suggest maybe 36 or at least to avoid hyperthermia of any sorts for the few hours that he's going to be transferred down.
Okay.
Francis, Annick?
I'd agree with that.
Same thing?
Okay.
Yeah. Good.
Any questions from the audience so far? No? All right, we'll throw the slides back up here. Okay. Next set of questions. How long would you maintain TTM for? 12 hours, 24 hours, or 72 hours for the primary treatment of fever? Show of hands. TTM only for 12 hours. Raise your hand. TTM for 24 hours.
Yeah, that's mostly.
TTM for 3 days.
36 hours.
36 hours.
Yeah.
Second question, how would you apply it? Who would choose surface cooling technique, intravascular cooling technique, or ice packs? Raise your hand. Who would use surface cooling? Who would use intravascular cooling? Who would use ice packs? Okay, so this is not as controversial as I thought it was going to be. Everyone here did the pre-reading. This is taken from a paper that we just submitted to the European Heart Journal. We did a meta-analysis and a systematic review on a number of practical aspects of TTM application. We went through the literature and looked at all of these trials, looking at the independent effect of fever, which then pertains to the independent benefit of fever management beyond the first 24 hours. What is interesting is I think that the conventional wisdom, and certainly my bias, is that fever is bad. But there was at least one retrospective trial of fairly large size that suggested that, if anything, fever was protective in the post-arrest setting, which put a bit of a spanner in the works. So there is a bit of an inconsistent signal in terms of the independent effect of fever. And what is not known, and maybe I'll defer to Francis here, is that it is not known if fever is an independent marker of poor neurological outcome or per contributor, or just a marker of a brain that is otherwise going to do badly.
It's a very tough question. Either, I think, but fever has so many physiological impacts on CO2, on brain blood flow, on oxygen radicals and so on. It's very difficult to tease out, but generally it's well accepted that fever is bad for a recuperating brain.
Okay. All right.
And would you give, sorry, just to maybe complete that question, and a time frame, and would you say within most of any rebound brain edema within 24 hours, and then afterwards?
I try to keep it as
normal
as possible for as long as possible, but then it becomes difficult at some point, or you run into the 50% pneumonia rate of
That's right, exactly.
hypothermia. The shivering is a big issue. Shivering is associated with decreased cerebral oxygenation because of the strong metabolic cataclysm it creates in the body.
Okay. We'll put the slides back up. So I'm happy that our recommendations are actually congruent with what you said. We found no randomized data and very weak retrospective data that suggested there was an optimal time point. So what we did was we basically went back to the primary literature and looked at the protocols involved in these three, and we believed that the duration of temperature in TTM was probably the most reasonable target in terms of duration. However, we acknowledge the fact that the strength of the evidence would suggest that fever management is better than no fever management, and so therefore we put in a conditional recommendation to allow for the continuation of targeted management. Again, that sort of third leg in the TTM triad to prevent fever, but acknowledge that the evidence underpinning that was fairly weak. So I guess from a practical point of view, if you are going to use an intravascular cooling system and you're considering going beyond 24 hours, now I think you're a little concerned about the vascular complications of a large bore catheter in a femoral vein. And that might be somewhere where a surface cooling system might be a little bit more advantageous if you're going to go down this route.
Yeah, I agree.
So just an illustration of the different systems you can use to apply TTM. This ice packs, obviously on the left there. Back in the bad old days at VGH, this is what we used. These are sort of radio opaque, non-feedback controlled cooling blankets that were plugged into a machine that we just dialed in. You sort of sandwich the patient in between them. The three newer systems that are commercially available since then, however, this is the intravascular system, the Zoll Thermoguard, that has different lengths of catheters that are inserted under fluoro in the femoral vein, and it has constant circulation of fluid within these balloons. A fairly smart touchscreen, which allows for extremely precise temperature management. You can actually get temperature management down to about 0.1 degree, and the nurses set the temperature, set the rate of cooling or warming, and then they can walk away. And the machine does everything for you. It auto-calibrates. The equivalent surface cooling, this is the Bard Arctic Sun. Very similar interface as well. And here there are sort of fluid-filled channels in pads that are applied to the chest and to the thigh. There's three different sizes, small, medium, large. Like the Zoll system, this also plays quite nice in the cath lab. The thigh pads actually have cutouts in the femoral artery, so you can actually do angiography, and the pads are radio opaque. One system that is available, I'm not sure it's available in Canada, but this is available in the States, the Cincinnati Sub-Zero, which it looks a little bit more involved than the Arctic Sun. It's sort of like the Arctic Sun on steroids, basically. You put the guy in essentially a dress that's filled with cold saline that circulates. The interface here is probably not as elegant as the first two, however. So those are the three systems that you could purchase if you wish to use a feedback-controlled system, or you can go with cooling blankets. Now, in terms of which is better, again, this is taken from our systematic review. We looked at two randomized clinical trials, 3 observational trials, and bottom line, there really is no difference between any of the different methods. Probably a function of power, I would suspect, because the numbers are pretty small. And you can see the confidence intervals here, and some of them are fairly wide, but a couple of them are fairly tight. But the bottom line is what we recommended is that you choose a system that makes sense for your institution and just get to know that system well. Whether it's intravascular or surface cooling, just get to know that system well and use it accordingly. And so the choice of methods should take into account patient variables, equipment availability, and institutional expertise.
If I can ask, Graham, anybody have experience with the like esophageal balloon or gastric cooling? I've seen, I think about last year, there was a catheter that could be inserted like an NG tube or OG tube in intubated patients. It can cool it centrally, and I guess could be analogous to an intravascular catheter. Anybody in the audience have experience with the esophageal cooling? Or
No, I don't think so.
I guess it hasn't panned out yet.
No.
But,
Yeah. Okay, let's move on. Anybody have any questions about the TTM aspect of the management of this patient? So these are sort of more the nitty-gritty sort of bedside considerations, more than just the top line considerations that most people are familiar with. Okay, so there are 2 future trials that are going to go and explore sort of moving TTM further. Michel Lemay has a trial called Capital Chill. He's actually almost finished randomizing. I just spoke to him about a month or so ago. He actually is pushing the envelope for either mild or moderate hypothermia. You can see his 2 randomization arms here. So survivors of out-of-hospital cardiac arrest, he's randomizing to 31 versus 34 degrees Celsius using an intravascular cooling device. He has a primary endpoint which he believes is powered appropriately for death and neurological outcome CPC 3 or 4 at 6 months. I've also spoken to Nielsen, who was the TTM1 author. He's now proceeding with TTM2. There's actually a website that has been popped up. Again, a very similar cohort of patients, and this is going to speak to some of the issues that were raised with TTM1, whether it was fever management versus true hypothermia. So here he's actually saying 33 versus no fever. And no fever would be anything south of 37.8. So this would be a true sort of test of the hypothesis. Is it preventing fever versus hypothermia? That's and so this is going to be randomizing soon. They've actually in North America, they've already got ethics approval in Europe. The TTM here is maintained for 28 hours, and they have a fairly robust power calculation to allow for an all-cause mortality endpoint at 6 months. Okay, so let's move off of TTM. How are we doing for time, JF? We're good?
We're good.
We're good. Okay. All right,
15 minutes,
next
I would say.
question. Who wants to take this man to the cath lab? Raise your hand. You saw the ECG, you saw his demographics, and you saw his baseline hemodynamics. Raise your hand, who wants to take this cath? Okay, so the next question, when would you take him? If so, would you take him immediately, within 24 hours, within 72 hours, or only once you determine what his neurological status is? So no, let's vote. Who wants to take him right now, much like a STEMI? Raise your hand. Couple of hands.
Now he's stable. He has left bundle branch block. That's new.
New left bundle branch block
That's
with
maybe the
third-degree heart
reason
block.
to go as a STEMI or something,
Yeah.
maybe.
And he's now got a transvenous pacemaker in. His blood pressure is 100, and his paced rhythm at whatever his paced rhythm was at. Intubated. Yep.
So is he in complete heart block?
Complete heart
with
block.
ventricular escape, or he has a left bundle branch block? Because I know the morphology
Yeah.
looks like
Yeah.
a left bundle branch, but looks like is in complete heart block. So if the escape rhythm is ventricular, we cannot talk about a left bundle branch block.
This is true.
That's
So
a good
we
point.
interpret it as alternating bundle branch block,
Okay.
as opposed to an ischemic left bundle branch block was how we approached it in the ER.
But he had no prior heart disease. Am I correct?
No prior heart disease, but we didn't look. So we had an echo on him in 2012 that was normal.
Normal.
Very bad PFTs and a chest X-ray suggestive of COPD, heavy smoking history, never had ischemic symptoms on ambulation, so we believed his shortness of breath, which is the reason I saw him in 2012, was all respiratory, and he got better with inhalers. But he's a 79-year-old guy
Yeah. No,
who
he
lives
probably has
North
a
American
coronary disease.
lifestyle,
But the initial rhythm was VF.
and he had VF.
Because we could say, okay, he coded because of alternating RBB and LBB, but he had VF.
Yeah.
Well, the-
Okay, so let's go back
and
to
he
the
has no
slide.
contraindication to go to the cath, so I would kind of favor maybe more rapid cath. Would it be immediate as a STEMI, or, depending on where he is, but I would definitely want to know the anatomy in this patient.
Okay. So,
As he needs a pacemaker anyway, so
yeah.
just
So his
put the
transvenous
pace and do the
pacemaker,
angio, so
the
He
fellow had
already
already
has
put
it
it
in
in.
place.
He already has a pacemaker.
He already
Pacemaker
has a
is in
pace.
place.
But it's true that, yeah.
Second question, when should you start TTM if you take in the lab? Before angiography, during angiography, or after angiography? Who wants to start him in the emergency room?
As we prepare
In
the cath lab.
the cath lab along with the Judkins catheters. After he gets back from the cath lab in the CCU. Okay. So we do have a little spread of opinion. Any thoughts in here?
I would say the earliest. If you wait 2 hours to go to the cath lab, I would start it off. If
Okay.
you have the devices, feedback ones that it permits to go to the cath lab.
Okay.
Again, kind of logistically, I wouldn't necessarily delay a cath lab if it was available
Yeah,
to put
exactly.
on pads and stuff, but
Okay. All right. So, I'm going to see if I can run this here. There you go. So, before you run it, predict the coronary anatomy.
I see it.
Okay, so I only gave you one shot of the LAD, and this is eleocranial, but there was minimal coronary disease in the left system. Minimal, 10, 20%, and that was generous. Well, we're on the right. Normal. This guy had essentially normal coronaries. Okay, so this would fly against our bias. 79-year-old gentleman, ex-smoker, presented with VF, has potential ST elevation in VR that the fellow was concerned about, had essentially a normal cath. And his ejection fraction was 60% on the ventriculogram, with no wall motion abnormalities whatsoever.
do we have an echo for the right ventricle dimensions?
Yeah, the echo, we did have an echo. I didn't put the echo findings here in the report, but I do have the report. The echo was unremarkable.
Okay.
We were looking primarily after the angiogram and the ventriculogram for potential for an infiltrative process, although it'd be weird for a gentleman to present with an infiltrative process at 79 years of age. We would have expected that far earlier.
Yeah, but I mean, it's just that the first EKG he had a few years ago showed a left axis with a right bundle brain block, but the Q waves in the inferior were not that large.
No.
The second EKG he had fairly large Q wave in inferior. So,
Yeah.
I mean, there's always pulmonary embolism that could be
Absolutely.
discussed.
So we thought about aortic dissection, we thought about PE. I don't recall whether or not we did a dedicated PE study, but on echo, his pulmonary arteries were normal, his pulmonary systolic pressure was normal, he was not hypoxic, and he had really no symptoms in retrospect when we talked to him when he woke up that would have suggested he had a PE. Let's go back to the slides there. So I'm just going to go and, as I said during the guidelines discussion, that there was a lot of controversy about the benefit of angiography in the setting of hospital cardiac arrest in the absence of acute ST elevation. Lots and lots of cohort studies, nothing randomized. I've picked two of probably the best cohort studies. One of them is the PROCAT2 trial that was published in JACC Intervention. This was a fairly large trial. It was retrospective, not prospective, and it was a cohort study looking at a conglomeration of around 700 patients culled over a number of years who had cardiac arrest, some of whom were taken to the lab. As you can see, about half were taken to the lab, and of those, about 200 actually had PCI. On the right-hand side, the investigators looked at the indications and suspicion proportion of people in whom it was felt clinically necessary to take to the lab. Now, this is non-randomized data, so this is clinical judgment that decided whether or not an individual went. And as you can see here, they broke them up by age, by type of rhythm and by gender. And you can see the different proportions of individuals in whom the clinical suspicion for ACS or an underlying coronary culprit was, and it was highest in the male over the age of 50 with a shockable rhythm. If you take a look and shake and bake the data, they suggested a favorable outcome with PCI with an odds ratio of 1.8 with confidence intervals fairly tight. If you look at the paper, however, it is unclear from ProCat2 the timing of when they went to the cath lab. I looked everywhere in the paper. They didn't tell us, did they go immediately, within 1 day, or within 24 or 72 hours. Now, again, this is aggregate data over a number of years. Probably very difficult to get that number out. There's a question here.
Sure. Juana Simeon, Charlotte 1. I was wondering whatever happened to troponins. Now we have high sensitivity troponins. Within 3 hours, by the time you cool them down, if you have only a reason to 200, which might be explained by massage and the shock of just cardiac arrest, I mean, it could guide your management as opposed to troponins of 2,000 with left bone branch block.
Yeah, we actually specifically talked about that. Unfortunately, although it's a very tempting target or a tempting factor to hang your hat on, troponins are wildly nonspecific and not particularly sensitive in the setting of out-of-hospital cardiac arrest. So we actually specifically recommended we do not base a decision on angiography on cardiac troponins.
Yeah, very good.
I guess the problem is that if you're really, really early and troponins haven't had the time to go up yet and stuff, I mean.
Yeah. So the ProCat2 trial is the one in which the angiographers tend to quote if their bias is we should take everyone to the lab, okay? The countervailing argument, however, comes from the angiographic subgroup of TTM. And in here, I mean, there wasn't protocol mandated that everyone went to the cath lab in TTM, but they took about half of the patients in TTM, of which they did angioplasty on half again. Now, if you look at that paper, 2/3 of them received angiography within 2 hours. And you can see the Kaplan-Meier curves here, very, very different than what they saw in ProCat. There was no independent benefit of angiography and revascularization in the TTM population. Again, were the populations in ProCat different from the populations in TTM? ProCat, the patient cohorts dated a little bit further back than the ones in TTM, so I think that probably accounts for some of them, as Anik had elegantly outlined, that sort of ICU-like care probably may have dulled any of the benefit of angiography here. But the odds ratio for here was a very disappointing 1.03. And I think this illustrates the range of literature that underpins the recommendation for angiography. ProCat2, 1.8 odds ratio for a favorable outcome, and it's essentially a wash with the TTM's angiographic subgroup. So it was basically on the basis of this that although we recommended that you make a best guess call to try to guess whether or not there's an ischemic underpinning to your arrest, we don't recommend sort of cath for all, and we don't actually recommend a timing for all. We believe that the best we could have said in our trial, and I know that it's probably unsatisfying to a lot of people, is if you have a suspected cardiac etiology without ST elevation, go as soon as feasibly possible. We struggled at many time points. We struggled at putting a number in because a lot of people wanted a number put in. We could not in good faith put that number in the absence of data. JF, do you want to sort of...
Yeah, well, there was a long discussion at the committee, a lot of comments from the reviewer, and also in Canada because of geography, so it was very difficult to kind of come up to really consensus, and that's what guidelines are. It's a guide, so if you think it's acute ischemic event, have STEMI or even have recuperated the STEMI, but you think it's acute ischemic, then you should go quicker as a STEMI. If you don't think it's that situation, then you have time maybe to reevaluate. So the knowledge, like Jean-François Gobet said, that he's asked by the ER physician to bring everyone to the lab, that's clearly not what the guidelines are suggesting. I hope this is clear to all of you today. It's our judgment, and it's not troponin. I mean, it's a combination of factors. It's our judgment. The other thing I think we put down, maybe, he said there's maybe some patients that have no benefit of the lab. So those who have very bad prognosis, who are, and demented, have cardiac arrest, sometimes they want to transfer to our hospital for a cath. There's no indication if someone was, I mean, it's obvious to you, but we do get some of these calls. I'm sure some of you have those calls. So someone who has no quality of life, who's, on palliative care, has a cardiac arrest. I mean, there's no guidelines to recommend to bring to the cath lab. And Jean-François, you probably have some of those calls. Not frequently, not every week, but a couple of times a year, I would say.
Yeah.
I'm sure in Vancouver
Or
too.
prolonged arrests as well.
Prolonged arrest. So
for
there's
them.
some characteristics that have very poor prognosis, and unwitnessed arrest that comes in there.
I completely agree with you, but anecdotally, I mean, I work in a cath lab hospital as well. We often have a patient or a physician wishing to transfer, and I'm not going to say it in an excuse, but the reason that they want to be transferred is they need a cath. And I think that if you read between the lines, it is the only way that they can sell a patient to get them out of their emergency room to come and to our institution versus another. When we tell them that there's no benefit of the cath, that's when we get some of the pushback. But I suspect that the reason why people are pushing for a cath is they want to pass the buck on to someone else, and there's something tangible that someone else can offer them that in their own mind they think this is going to be something I can at least do. Unfortunately, the literature just does not suggest that that thing you're offering is going to make much of a difference, unfortunately. And randomized data is coming. So if you just...
So then, Guy, for all those patients that you decide maybe not to take to the cath lab that have a risk of coronary disease or ischemic disease because of a shockable rhythm,
Yeah.
you treat them all with heparinoids and dual antiplatelet therapy?
Yeah, and I think that's it's an excellent point. In our institution, if I think it's an ischemic etiology, I would cath them. The main question is if you're up in Chibougamau and you decide not to transfer, would you treat? I'm not sure I could answer that, actually, to tell you the truth. I don't know what your thoughts on that.
Well, again, if it's far away, and it depends if you think it's ischemic. But that point about antiplatelet is very important. We did discuss that, and the action of antiplatelet therapy, if you give them and they're on temperature control management, there's some delay. Okay, so at some point, if you get to the lab, it's a thrombus-containing lesion. Even if they receive the powerful antiplatelet agent, probably you should give some maybe IV if you need. If you have, because there's more delay in absorption and metabolism of these agents.
Michel Lemay has done some nice, elegant work that temperature of 32 or 33 essentially inactivates clopidogrel because of the conversion from the prodrug. You also get some blunting of ticagrelor and prasugrel, but not nearly to the effect as you get with clopidogrel. So
and that's where cangrelor could be of use,
yes,
or to
absolutely.
be treated if you do need. Not don't give them systemically, but if you need.
And that's the other reason that our institution has switched more from 33 to 36. If you're considering taking to the lab, we know that the lower temperature basically will make your angiography much more dangerous because your antiplatelet just won't work.
Exactly.
Okay, slides back, please. So there is one trial that's looking at taking all patients who survive a cardiac arrest to the lab early, and by early it's defined as less than 2 hours. This is being run at the University of Arizona. This is the PEARL trial, and the randomization schema is early versus non-early, but even the non-early is 6 hours, so it's still fairly aggressive. Concomitant TTM is mandated. The primary endpoint is what they describe as safety and efficacy of angiographies. They're looking at a net sort of accounting for any adverse events from the cath versus any benefit. Bleeding, stent thrombosis, re-MI, and this is more of a pilot proof of concept trial. I think there are only going to be about 600 patients in this trial. But this is ongoing right now and will give us a little bit more information as to the timing that was mentioned before. We do know that TTM is beneficial only if it's given early, and that if you have acute ischemia with high risk features, the benefit of angiography is also front-loaded earlier. So our recommendation was that if someone is at high risk for neurological injury and requires TTM, but also is at high risk for a cardiac problem requiring early angiography, make every effort to initiate both, which is why I think the discussion with the TTM system in your hospital is much more important. Okay, so we're coming close to the end. I want to leave some time for questions, but I just want to give you a sort of a blow-by-blow of what happened to this fellow. He spent 2 weeks in the CICU. He made a complete clinical and neurological recovery. He had an implantation of a single-chamber ICD. His discharge echocardiogram demonstrated normal LV function without any evidence of infiltration. He was so grateful, he is now one of our spokespeople for the VGH Foundation. His name is plastered all around our campus. And he's actually a fairly famous guy. This is him. The patient is Mr. George Bowering. I actually didn't know this, but the House of Parliament in Ottawa has someone called the Poet Laureate. And he was the inaugural Poet Laureate for the Canadian House of Commons. And he's a very prolific author, a very prolific poet, and it's a testament to his remarkable recovery that subsequent to his arrest, he's written 6 books. So he arrested in 2012, and you can see all the books that he wrote after his cardiac arrest. So again, illustrating the fact that, he had many of the features that would suggest he would not do well. He's old. And even though he had a very, very prompt recovery, age is often the thing that biases against aggressive care. He is, I would suggest, the exception that proves the rule, but again, it illustrates the fact that you probably shouldn't give up on people that you might think you should give up on, and that he's also illustrated what Dr. Fordyce's paper would suggest, that if you make it outside of the hospital, you have very good chances of doing real well. So with that, I want to end by saying that a comprehensive and simultaneous management plan encompassing TTM, angiography, and optimizing various hematological, hemodynamic, and biochemical profiles should be applied to survivors of cardiac arrest. And with that, you will increase your chance and likelihood of survival to hospital discharge. And with that, I will end. Thank you.
Thank you very much. So,